use because it used to produce antibodies. Now this is the recombinant DNA technology, and human insulin is the one which is commonly being prescribed. The pork one is no more, or beef pork is no more in practice. Onset and duration of effect, change in the properties of insulin preparation. So if insulin molecule is changed a little bit, alters the onset and duration of action. So we have Lispro, which is a monomeric, very rapidly absorbed. Aspart, which is mono and dimeric, is also absorbed rapidly. So these are short-acting ones, short-acting ones. Regular is absorbed rapidly, but it is absorbed slower than the Lispro and Aspart. So this, when you prescribe to the patient, you tell them take them with the first bite of the food, and this is when you prescribe them, you tell them to take them at least 15 minutes before taking food. These are called short-acting insulin, and these are basically used for the parenteral glucose, or for the rise of the glucose with the food intake they are used. Then there is long-acting insulin, lent insulin. It's a precipitate of insulin with zinc and insoluble crystals of insulin zinc. It is slowly released in the body. NPH, which has regular insulin along with protamine zinc insulin, so it is also released slowly in the body. And then we have glargine. It is a modified structure of insulin having microcrystals, and it is released very slowly in the circulations. This cannot be mixed with other insulins. So these are the insulins which are used as basal insulins. So these are given once or twice a day, and they maintain a level, a basal level of insulin throughout the day in the body. So what is the side effects? This can cause hypoglycemia. That is the main side effect. So patient has to be aware about hypoglycemic symptoms, the palpitations, the sweating, the restlessness, and the feeling of taking food. And whenever they have hypoglycemia, they have to be given 10 to 15 grams of glucose. This glucose should be given, the patient is advised to take juices, or he can take a glass of water with 2 to 3 spoons of sugar in it, or a glucose, or we have 15% or 25% glucose ampules available. You can, that is also given. And if patient is lost to conscious, then you give IV dextrose to this patient, or 1 gram glucagon IM if IV access is not available. So if you cannot give IV dextrose, then glucagon can also be given to them for hypoglycemia. So patients at the site of this injections, they can have skin rash, and it is usually more, so treatment is to give them more purified insulin preparation. Lipodystrophies, increase in fat mass, can occur at injection sites, so you have to advise them to rotate the sites of injection. So there are several drugs which can interfere with the glucose tolerance. Diazoxide, thiazide diuretics, which are commonly given to patients of heart failure. Corticosteroids with autoimmune disorders and several other disorders. You give corticosteroids that can cause increased levels of glucose, can cause hyperglycemia. Oral contraceptives, streptazotine, phenytoin, they all can cause the levels of the glucose to go up, and monitoring of blood glucose is required in these patients. So how will you give the insulin? You can give insulin with syringes or needles. There can be pen-sized injectors, and now the insulin pumps, newer therapy. The goal in type 1 diabetics is to balance the calorie intake with the glucose lowering process, insulin and exercise, and allowing the patient to live as normal as possible. So you have to maintain the diet with the insulin and exercise. They have to be managed in a way that patient lives a normal life. This is what I was talking about, the parenteral. So what happens, there is a surge of insulin the whole day. There's one basal level of insulin which is not shown. You can consider a line going through and through over here. So an insulin basal level is there, which is there throughout the day, and when a patient takes food, then there is surge of insulin. So when you have taken a breakfast and the glucose level, as the glucose level rises, the insulin level rises. Then again, as at lunch, you can see there is a, when you take the food, there is increase in the glucose level and there is increase in the insulin level. And then supper or at dinner time, again the same thing happens. So this is how normally insulin is produced in the body, and this is what we try to mimic in type 1 diabetics or in type 2 diabetics when we put them on insulin therapy. So the short acting insulin, when you give short acting insulin, you give it here when the patient is taking the food. So that short acting will cover the breakfast, and then another dose of short acting will cover the lunch, and the third dose will cover the supper. And the basal, the long acting NPH or the glargine or lentils which you give will cover the basal levels of the insulin. The line is not apparent here, इसी वजह से नज़र नहीं आ रही है इस ग्राफ की लाइन इसमें प्रोजेक्ट नहीं हो रही, but you can think that there is this basal insulin, it stays like that throughout the day. So for that insulin, to maintain that level of insulin, you give the long-acting insulin to the patient. So the insulin regime has to mimic the physiological secretion of insulin with availability of the self-monitoring or continuous glucose monitoring and HbA1c test. The adequacy of the insulin regime can be assessed. More intense regime require more intense monitoring. So the more intense the therapy is, more the insulin injections you're giving to the patient, more you will have to do the blood testing of these patients. So there are several examples how you can give. You can give a morning dose before breakfast, give a regular and NPH or lentils, and then you give an evening dose with regular or NPH. Requires strict adherence of the timing of the meal. So you fix the time of the meal. 8 a.m. in the morning, 8 a.m. in the evening, they have to take their meal and their injections. So you can give them twice a day, or you can these, and then there can be several modifications in this therapy as well. So at the night, what you can do is that you can also give at the meal time, you give the regular, and then going to the bed, when patient is going to bed, then you give NPH. You don't give it along with regular with the at the time when he's taking the meal. You do it when he goes to the bed. Or you can give 3 injections of regular or rapid acting insulin before each meal and long acting insulin at bedtime, 4 injections. This is the best regime to follow. The choice of the regime will depend on the patient. So how much it depends on the patient, his health, his daily activities, his ability to take insulin to work. So it all depends on that. His ability to inject himself insulin. It all depends on that. So how much insulin you need to give? A good starting dose is 0.6 units per kg per day. Total dose should be divided 50% for basal insulin and 50% for prandial insulin. And then this 50% prandial insulin is divided into equal 3 doses. So for example, you have a 50 kg man, so you give a total dose. The total dose will be 0.6, the standard dose units, into the weight of the patient. This will give you 30 units per day. So 50%, like 15 units, should be basal, can be administered 1 or 2 doses. So when you give 1 dose, you give full dose together, or you can divide this 15 into half and give the 2 doses. And you have prandial, 15 units for prandial or for the meals, and you divide it into 3 equal doses. So that means 5 units for the pre-breakfast. Sorry, this one is wrong, it's equal doses. So 5 units for pre-breakfast, 5 units for pre-lunch, and 5 units for pre-supper. This is wrong, this is old regime, so you do not follow the 25%, it's 15-15, it has to be equivalent. It will be equivalent. So 5 units in the pre-breakfast, 5 unit pre-lunch, and 5 unit pre-supper. So how for type monitoring type 1 patient requires, so 0.5 to 1 unit per kg per day is the most type 1 unit. So most type 1 patients will require this much insulin. So you calculated it by 0.6, so you might need to bring it down to 0.5 unit per kg per day. So the range is between 0.5 to 1, and it is modified depending on the symptoms of the patient, the monitoring, the blood glucose monitoring the patient is doing, and the HbA1c of the patient. So according to that, you can decrease the dose or increase the dose of the pharyngeal or of the or the long acting. Insulin pump therapy. This involves continuous subcutaneous administration of the short-acting insulin using a pump. So a small pump is attached to the body, and that pump keeps on giving the insulin. It can be programmed to deliver basal insulin and spikes of insulin at the time. So it can be programmed. You can give, it will give a continuous short-acting insulin as continuous, and at the time of the meals the patient can adjust the dose, give input to the pump that he's going to take that much carbohydrate or food, and then the pump will give the spike of the insulin. This requires intense self monitoring, blood glucose monitoring, and this is the best time when you can do continuous glucose monitoring. So most of the insulin pumps are now being connected to the continuous glucose monitors. Requires highly motivated patients because failure to deliver insulin will lead to serious consequences like diabetic ketoacidosis. So this is two ways. You take a sample and you see, you check the glucose and then ingest the dose. Or you can use the insulin pump. This is the insulin pump which is attached to the body. Then it has this transducer, and then this is the sensor which is attached to the body and senses the glucose levels. So the uh, this this is a smart thing. Insulin pump is very smart. It will see if the sugar levels are falling, it will beep and it will stop automatically, or it will beep and advise the patient to stop the insulin. And if the sugar levels are high, it can be programmed to increase the dose of the insulin if the sugar rises. So whenever the sugar will rise, it will sense it and increase the dose of the insulin. So doses instruction are entered into the pump small computer, and the appropriate amount of insulin is then injected into body in a calculated controlled manner. So here it is attached to the body through the clothes, and this is the transducer, and this is the sensor which is fixed on the body. Surgery. Islet cell transplant has been investigated as a treatment of type 1 diabetes in selected patients with inadequate glucose control despite insulin therapy, and it has been seen that islet cell transplant have helped a lot of patients. So what we do is we take the islet cells from healthy islet cells. First HLA matching has done, and then healthy islet cells are taken and they are then injected into the hepatic vein, and which then goes, these cells then they go and settle down into the pancreas. Another is the pancreatic transplant. So kidney pancreatic transplant is is also being done and has shown good results. I think we can end it now. There is new advances, a few slides on new advances in diabetes and treatment. Incretins, what should we do? Okay, let me see how many slides are there. How many more slides are there? There's it's a few more slides, so let's get on with it, huh? Oops. Oops, 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 oops. Sorry. Okay. Okay, so incretins, we have